Welcome to KidzDocTalk with Dr. Jennie. Today's guest is Dr. Tehilla Steiner, talking to us about pediatric eye conditions. Dr. Steiner is a fellowship-trained pediatric ophthalmologist and adult strabismus surgeon. A native of New York and New Jersey, Dr. Steiner graduated from Yeshiva University Stern College for Women. She obtained her medical degree at the Albert Einstein College of Medicine and completed her internship at Abington Hospital and ophthalmology residency at Northwell Health. She was selected as chief resident in her final year and then went on to complete her pediatric ophthalmology fellowship at Montefiore Medical Center. She specialized in pediatric ophthalmology and adult strabismus. In her spare time, she loves cooking, baking, and riding her Peloton bike. Welcome, Dr. Steiner.
Welcome to KidzDocTalk with Dr. Jennie. Dr. Jennie is a board-certified pediatrician and is the director of telemedicine at Pediatric Associates.
Hi, Dr. Steiner. Thank you so much and welcome.
Oh, thank you so much for having me. I'm really happy to be here, Dr. Berkovich.
Thank you. All right. I'm excited to talk about all eye-related things. So you are a pediatric ophthalmologist. So before we talk about what you do, tell us what does that mean? What does that actually mean? And how is that different from an optometrist?
So that's actually a really great question. And a lot of people don't know the difference between the two. So an ophthalmologist means that the doctor went to medical school, and we are trained in so we go to medical school for 4 years, and then we do an intern year in general medicine. And then for 3 years, we train in all eye conditions, from children to older people, every type of eye disease, and we are trained to do surgery. And then I would say the majority of people after training go on to do a fellowship, which is further subspecialization in the eye. And so I did training in pediatric ophthalmology and adult strabismus. So I specialize in children. So I see children in the office from 0 to 18 years old and adults who have an eye misalignment. And the way that we differ from optometrists is that optometrists, they also go to postgraduate school after college for 4 years, where they learn everything about the eye. And they're really great at refracting and doing contact lenses and basic eye exams, but they are not trained in doing surgery on the eye.
Okay. All right. Fantastic. So tell us some of the typical things that you see. What are some common conditions that you see kids for?
Sure. That's a great question. So let's start with the babies. A lot of babies that we see, many of them have tear duct obstructions, which is very common. About 7 to 9% of babies that are born with tearing of the eye, which thankfully 90% of that resolves on its own by the time a baby's 1 year old. So that's something very commonly that we see. We also see babies who might not have a good red reflex that the pediatrician sends to us because maybe there's a cataract developing or something is obstructing the view where the pediatrician doesn't see a good red reflex. And sometimes we see babies that fail basic eye screening tests. Some pediatricians start screening the babies at 1 and 2 years old. So if there is any kind of refractive error, we see babies like that as well. And then as children get a little bit older, we see children for eye misalignments, meaning the parents might notice that their child's eyes are crossing, going in towards the nose or drifting out towards the ears. We see children for basic eye exams. Maybe the parents notice that the children are standing close to the TV, or the teachers are telling the parents that the child is struggling in school. They're squinting, they can't see the board. We also see children a lot for headaches. You always want to make sure that there's no eye component to the headache. Those are a lot of the types of things that we see.
Okay, so you mentioned babies, and as a general pediatrician, when I think of babies and eyes, obviously the first thing I think of is red reflex, right? We know that's super important. Sometimes, like, we notice, right, eye laziness or kind of misalignment, as you called it. Talk to me a little bit about like the typical normal development of vision in babies. Do babies start seeing right away? Are they born seeing exactly what we're seeing? And how does that kind of develop as they grow?
That's actually a really great question. I get that a lot. So babies are not born knowing how to see. You actually learn how to see. So that's why if there's any issues that might be obstructing the vision, you want to address it right away, because the first few months of life are really crucial in vision development. We're not babies, so it's not like we could ask a baby, oh, do you see the big letter E on the chart? But a lot of the studies show that babies probably see around like the big letter E at birth, around the 2400 line. And they see a lot of black and white, not so much color. Color develops as they get older. And it's very typical. This is also something that I get asked a lot. It's very typical for babies for their eyes to be misaligned up until 2 to 3 months of life. And the reason for that is because they are learning how to see. Things are not really in sync with each other. So sometimes parents get nervous. They come in when the baby's maybe 6 weeks old and they say, well, they're not really following me, or their eyes are looking cross-eyed. And, as if there's no ocular pathology on the exam, we usually give reassurance, because things sort of tend to correct itself as the baby gets a little bit older. But if a baby still has, let's say, an eye misalignment at 3 or 4 months old that's persistent, then we definitely would say come into the office for us to check it on out.
Okay. So when do you say, when do we think babies have the same sort of expected to have the same acuity of vision that we do in adulthood? When should I expect a baby to see exactly the same thing that I'm seeing with colors and all of that? Do we know that?
Probably within the first year of life. But the thing is, as adults, we have to understand that we use our vision for things in the distance and for things up close. But babies, their entire world is everything at near. So we want to make sure they're able to see things at near. So what do I mean by that? I'll give you an example. Let's say we have a baby that comes in, they fail their vision screen and they're a little bit nearsighted, which is called myopia. That's the medical term, which means you could see up close but not far away. We might not necessarily give that child who's a little bit nearsighted glasses, because we need to make sure that they could see things up close. They're not using their distance vision until they go to, let's say, VPK or kindergarten, probably within the first year of life, I would say. Yeah.
Okay. All right. And so that brings me, I think, to vision screening and the importance of vision screening. So you keep mentioning babies and vision screening. And so I think that's not necessarily organic to some people. When I think of vision screening, I think of school age kids, when they can actually tell me, right, what it is that they're seeing, and I can assess if there's any kind of deficit. So tell me a little bit about how vision screening works, especially in younger babies, and how valuable is it for us to be doing early on?
Oh my goodness. It's early intervention. It's huge. So we are very blessed that we have technology that we didn't have, 30 years ago or 20 years ago, where a lot of the pediatricians in the office, as you know, there's a special machine where you could take a picture of the eyes and it comes up with sort of like a basic prescription of what that child has. They're not always 100% accurate, but it's a really good starting point because it can catch a lot of issues. See, the thing is with children is that if they're not seeing clearly, the majority of the time, they don't realize that they're not seeing clearly. So parents usually say to me, but my child wasn't complaining. I didn't know. And it's because the child doesn't realize that they weren't seeing clearly. So when the pediatrician does the vision screening where they take that picture of the eyes to see, does the child need glasses or not, it picks up on a lot of issues. And we always recommend that children should have their first eye exam anywhere between 3 to 5 years old, especially before they start school, because we want our children to succeed in school. And it's very hard to succeed in school if you are not seeing well. Now, we also say that if a parent or pediatrician has a concern before the age of 3 to, of course, come in to be evaluated. But definitely it is so important for a child to have even a baseline evaluation, because we want to, if they need glasses, we want to intervene at a young age to make sure that the child develops good vision. And I'll give you an example. And I've seen this, unfortunately, way too many times, where I've seen 10, 11, 12, 13-year-old children come in, and the parents have said that the child has never complained about having any eye problems before. And one of the eyes is considered amblyopic or poor vision. It's a lazy eye. And that child, unfortunately, has a blind eye where they see very poorly. And if there was intervention when the child was younger, it could have been avoided.
Wow, that's very powerful. So let me ask you, in terms of referring and referring early, which sounds like it's
Yeah.
critical, how do we know? Do we always need to be referring to a pediatric ophthalmologist, or can we sometimes start with an optometrist to have the child evaluated? And then if there's any kind of concern for abnormality, then we escalate.
That's also a really great question. So, as a pediatric ophthalmologist, we have specialized training in children. And in optometry, I don't want to misspeak, to be honest with you, Dr. Berkovich. I don't know how many pediatric fellowships there are for optometry, so I really don't want to misspeak. But one of the things that we are very comfortable with is children who are nonverbal, who are developmentally delayed, who do not speak. So I could do a full exam and know exactly what is going on with the child, what the refraction is, how their retina looks, how the front of their eye looks, without them even talking to us. We see a lot of children who are developmentally delayed who don't speak, and we're able to provide that service for them. And we do get a lot of referrals from optometrists that might not necessarily feel comfortable treating children like this.
Okay, that's helpful. That's kind of helpful sort of guidelines for figuring out how that referral process should work. You mentioned amblyopia, and I want to talk a little more about that
Sure.
because it's a scary sounding word, but I think it's probably not as scary as
Sure.
much when we talk about what it is. So define it for us. Like, how common is it? You see it often, and what can be done for it?
Sure. So amblyopia basically means poor vision in an eye. So you have to ask yourself as a physician, when I see a patient, why is this child not seeing well? And there are many different reasons why a child could have poor vision. So one is what we call deprivational, meaning there was something that was blocking their vision. Is it because they were born with a droopy lid and that blocked their pupil? The pupil is the black circle that helps let all the light enter into the eye. So was there something that deprived a child from vision? Was it droopy lid, or was a child born with a cataract, or they develop a cataract? A cataract, just to explain to people what that is, there's a structure in the eye called a lens, and it's supposed to be a clear structure. And as we get older, it's more in the elderly where it opacifies, where it becomes darker and it's harder to see. But there are some children that are born with that. So that could be one reason why a child has poor vision. Another reason why a child could have poor vision is because they have a strabismus, which means an eye misalignment. Their eyes aren't straight. Either the eye is crossing or it's going out. Another reason why a child could have poor vision in the eye is because they need glasses. Something as simple as they need glasses. They could either be farsighted, they could be nearsighted, they could have astigmatism, or they could even have a difference in prescription between the two eyes. And the way that the brain works is the brain favors the eye with the lower prescription and uses that eye, and the eye with the much higher prescription, the brain likes to ignore that eye. And that's actually something that we see very, very commonly. I don't know the exact percentage of amblyopia, but I would say that it's very frequent. But as long as we see a child when they are young, there are so many interventions that we could do to help improve a child's vision. And again, intervention is key. The earlier a child is seen, the better off it is for a child in their visual development.
Okay, fantastic. So what are some common interventions, and I guess maybe walk us through like a spectrum depending on how severe the deformity or the abnormality is, and I guess from least invasive right to most invasive, which I'm guessing would be surgery.
Okay, so let's start with the most basic reason why children come in is because they have a refractive error, meaning they need glasses. Either they're farsighted, they're nearsighted, or they have astigmatism, which really describes the front of the eye, how the front of the eye is shaped more like a football than a circle. So usually, not usually, when the patient comes in, every single time we refract them, that means we figure out what their prescription is. And if they need glasses, we give the parents a prescription to go to a glasses store, to an optical to get glasses. And most of the time, the child wears the glasses and it awakens up their vision. The brain says, wow, I could see clearly now with the glasses on. And the amblyopia, the poor vision, resolves. There are some times, though, that even when the child has the glasses, it's not enough and they need an extra oomph, a little something extra to help with the vision. And one of the things that we do is patching therapy, where we patch or we cover the stronger eye. And basically, you're forcing the brain to utilize the weaker eye. Children don't necessarily like that because all of a sudden you're covering the eye that's doing all the work and you're forcing the eye that doesn't see well to be doing the work. Another intervention, so you're saying from least invasive. So that is, let's say for somebody that has refractive amblyopia, that means that they don't see well because of a glasses issue. Then there are some children who their eyes aren't straight. And sometimes there are many different types of situations. Sometimes the glasses can help straighten out their eyes, and sometimes it doesn't. And some of those children will need to have eye muscle surgery or strabismus surgery, where basically, as a surgeon, I have to move the muscle into a better position to help straighten out the eye. Or if a child has, let's say, cataracts, you would want to intervene at a very young age, and that child will need to have cataract surgery where you remove the cataract. And depending on the age of the child, you may or may not put an intraocular lens into the eye. Or if a child has droopiness of the lid, they might have to go to a plastic surgeon for the eyes to lift the lid up. So those are the different things that we could do to help intervene for a child.
Fantastic. So it sounds like there's a lot of variability. I think my main takeaway from like all of this is early intervention. Like get them in, right? If you have concerns, if the parent has concerns, like right, earlier is better than sitting on it.
And I will say one thing is that, you know, even if it turns out to be nothing and the eyes are 100% healthy, the worst thing that happens is that the child gets the dilating drops and their eyes are blurry for 4 to 6 hours. That's how long the eye drops, the dilating drops for. I mean, that is really the hardest part of the exam. And you rather make sure that everything is healthy in the eyes. I mean, I'll tell you, I saw a child recently who was about 6 years old, and the parents told me that the child is delayed, and the child has such a high prescription. And once this child got the glasses on, it was like a whole new world for this child. And so then you wonder, is this child really delayed, or is it really because the child couldn't see anything, which really impacts all your development? I mean, if you can't see, how are you supposed to learn how to crawl, how to walk, your depth perception, how to interact with the world? I mean, without our eyes, what are we? I mean, our eyes is one of the most important senses.
That's really powerful, and actually is a great segue to my next question, which is vision therapy. So I get a lot of questions about this, and I find it's maybe, I don't know, happening more frequently now for whatever reason. Parents ask me about the value of vision therapy, and surprisingly, I'm hearing about it in context, not just of a potential visual deficit, but of like all sorts of things, like learning disabilities, right? Sometimes people whose kids are on the spectrum want to know about vision therapy. Talk to me a little bit about that, and do we think there's any benefit to it?
Okay, so it's a little, I'm going to be honest, vision therapy is a little bit of a loaded question in the sense that, I don't know if controversial is the right word, but there's two very different schools of thought between optometry and ophthalmology. So just to explain what vision therapy is, what the definition is, it's really a term used by optometrists, not by ophthalmologists. And vision therapy is really defined as an attempt to develop or improve visual skills and abilities and to change visual processing. Now, there's two parts to our vision, and I'm going to break it down, is that there's one part from paper to the eyes. That's one part of our processing. And the second part is from our eyes to our brain. So as an ophthalmologist, if there's an issue between paper to eye, meaning is a child need glasses, they're having a hard time seeing, let's say, quote unquote, the paper, that we could help with. But when it comes from the eye to the brain and the processing, unfortunately, there are no studies that show that there are any benefit to the therapies that are out there. However, there is one situation in pediatric ophthalmology that we see that therapy can help a child, and I'm going to explain what that situation is. There is an eye condition called convergence insufficiency, also known as CI, which is basically a fancy way of saying that the eyes are having a hard time converging or going all the way in towards the nose. So you can imagine when you're trying to read something, our eyes naturally try to converge, they try to go in towards our nose. So if a child is having a hard time with their muscles bringing their eyes in towards their nose and the eyes are drifting out, it can cause reading issues like skipping words when they read, skipping lines when they read. Sometimes some children could even have terrible headaches at the end of the school day, or they could even have blurry vision when they're looking from distance to near. And this is the one situation in pediatric ophthalmology where we do have exercises called orthoptics, where we could train the muscles to converge, to bring them in towards the nose. However, when it comes to the problems between the eye and the brain, the visual processing, unfortunately, there are no good therapies for that. And at that point, we really recommend a really good school psychologist to evaluate the child, or a really good reading therapist for the parents to really save their money and to use those resources to help the child out.
Okay, fantastic. I think that was a great answer to, I think what probably would have been, I know a little bit controversy around that, but I think that's really helpful and important context to have in terms of what works and what doesn't. So we talked a lot about abnormalities like early referral, right? Early intervention, identification. Sure. Let's talk prevention. What can parents do to sort of encourage healthy vision development, anything that parents can do to prevent some of these abnormalities from developing?
There are a few studies that show that by playing outside, the sunlight is actually very helpful in delaying myopic progression, meaning if a child is nearsighted or might become nearsighted, the sunlight is actually very helpful in delaying that. We don't understand exactly why that is, but there are some studies that show that. And the other thing that's also very important is try to not be on the device for many hours a day, the tablet, the TV, the phone. And, I'll tell you, Dr. Berkovich, before the pandemic, I was very strict with my children about screen time and TV and tablet time. But I have 4 children, and I, like any parent, was trying to survive the pandemic. And it got to a certain point where everything went out the window and my kids watch too much TV. So
let me just get rid of as a pediatrician, let me get rid of that guilt for you right now. There's no guilt around that. It's like I tell my patients, like survival mode, we're in survival mode. No, so that's 100%. Okay. Even, the AAP went back and revised some of the guidelines that we were giving for screen time. So whatever guilt you had as a parent, it's gone. My magic wand.
I really appreciate you saying that. No, I mean, because I tell the parents, because some parents get very upset when their child comes in and their prescription has increased. And I tell them, I'm like, we're all trying to survive. No, I agree 100%. The past 2 years has really been about survival. But I will tell you, and something that I have seen over the past 2 years is because of the pandemic and children have not been outside and they've been on the screens all the time, the progression of nearsighted has increased tremendously. And usually we see myopic progression that when you're nearsighted, it's supposed to be that your eyes grow and the prescription changes, but at the rate that it's growing has been so much higher through the pandemic. And it's very hard. It is very hard. I mean, one of the things that I do try to tell parents is that if your child is going to be on a screen, try to at least give them a break every 20 minutes, close the eyes, let the eyes rest for a few minutes, because when you're staring at a screen for a long time, you're not blinking your eyes enough. The eyes get dry. The surface of the eye gets very dry. You could get fatigue, headache. So it's very important that if they are going to be on the screen, to at least take frequent breaks if possible.
So is it the distance that they're sitting to the screen, or the amount of screen time itself, or like the combination?
It's not even so much the TV, it's more the devices that are an issue, to be honest with you. It's not really the TV, it's more the phones and the tablets.
So it really sounds like it's the screens are the issue. So, right, for example, I have a kid who likes to read a lot and she reads tons and tons. And a lot of times, like the book is right in front of her face. So that really is not something that you guys are seeing evolve into, issues later on, right?
No, I mean, that should be our biggest issue is that children are reading all day long.
Okay, so more outside time, less screen time. Sounds like all of that, right, helps. And that's almost always the answer to like a lot of issues in pediatrics, right?
But if possible, listen, like you said, it's really about survival, and we're all just really trying to survive right now.
Okay. All right. Fantastic. My next question was going to be, what are you seeing? Like, what changes are you seeing in your practice since the start of the pandemic? And I think you kind of answered that, right? You're seeing a higher incidence of vision problems as a result of increased screen time. 100%. Anything else that you're seeing like more of? Are you finding that people are maybe like ending up seeing you later than they otherwise would have as a result of pandemic fears? Anything similar to that?
I want to be very careful how I phrase this. Unfortunately, because of the pandemic, and the fear of seeing sick children, there have been, unfortunately, some misdiagnoses by primary care, which has been very sad, to be honest with you. And I'll just give you one example. I saw a baby, I don't know, a few months ago who had seen their primary care doctor for tearing of the eyes, and the parents were told that it was pink eye, and they came in to see me, and the baby had congenital glaucoma, meaning they were born with glaucoma. And glaucoma is actually one of the main reasons why a child could be tearing as a baby. That's what we have to, whenever we see a baby for tearing, we always have to make sure that it's not glaucoma. So I would say that if a parent has a concern about something and something is not sitting right with them, just to give us a call. We see emergency patients all the time. We have cancellations all the time. We have openings all the time. As a parent, we have a sixth sense. So if something just doesn't sound right to you, please call us. We'd rather it be nothing than be something, terrible.
Okay. All right. That's helpful. And hopefully, the incidence of that will start decreasing a little bit as people feel a little bit more comfortable.
And just to tell the parent, that's very, very uncommon. It just, not everything could be caught properly on telemedicine. So again, if a parent has a concern, please call us. We are seeing every patient, whether they're sick or not. I mean, I work with Dr. Biller, Dr. Kanterman. We're all triple vaccinated. I mean, we're seeing everybody. We're not scared. We're seeing everybody at this point. So come on in. Really.
Good. Fantastic. So that sounds like a good takeaway. Any other sort of like to tie this all up, any other major takeaways? What's like the one thing that you really want parents to know about healthy vision or about vision in kids? What's like your main sort of like message as a pediatric ophthalmologist?
Really early intervention, like we said, is key. I cannot stress that enough. Even if you do not have a concern for your child, please have them evaluated before they start school. Because again, if children have a vision issue, they don't always realize. And don't be shy to come in that if you're worried about something, it's important to address your concerns. If you feel like your child's eyes are crossing or going out, whether it is or isn't, have them evaluated. Like I said, the hardest part of the eye exam is having the eyes dilated. It's getting those drops in. And that only lasts 10 seconds. So really come on in. Let's make sure that your children's eyes are healthy, because early intervention is key to healthy eyes.
Fantastic. Thank you so much. This was so helpful. I learned so much.
Oh, it's my pleasure.
Thank you so much for your time.
Thank you for having me.
Make sure you like us on Facebook and follow us on Instagram and Twitter. Thank you for joining us on KidzDocTalk.